Hello and welcome to Season 2, Episode 69 of the Physician Assistant Exam Review Podcast. This week, we're going to be finishing up the ear. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review, and you can find all of the notes, everything you want to find over on the website, www.physicianassistantexamreview.com. That's where the notes for every show is. Where the notes for every show are. You can walk right through me there. I know a lot of people like to do that. You can, if you're having any trouble finding anything, you just scroll right to the bottom of the page. It's really very straightforward. There's only a couple options there. Click on Blueprint, and you will find all of the past shows, past podcasts, everything that you want to find for the website is there. In addition to that, with this particular episode and with most of the episodes, I'm going to be posting on this one. So if you go to episode 69, you'll be able to get a good chunk of the questions from the final step, the question book I wrote for ENT. Those questions will be available right on this page. So if you go to the website and click on that page, you'll be able to grab those questions. I think you'll really be, if you haven't seen them yet, I think you're really going to like them. Anyways, you can find all that over on the website. Where are we now? So we're in May. May just started. May is usually my favorite month of the year. We're starting baseball season. The sun is out. Things are looking great. This morning it's 46 and absolutely gorgeous outside. This is probably my favorite weather, just as the days start to get longer and everything starts to get a little, a little better for me. Obviously, things are a little bit different right now. Obviously, it's a little strange time. I know things are slowly starting to open up a little bit, but at the moment, everything's still pretty much closed. We are still not doing a heck of a lot of surgery at the hospital. We're doing some. I did a C-section yesterday. That was exciting. We're doing some fracture work, some stuff like that, but nothing like the volume we normally do. The ORs are closed down, except for a couple of rooms. The PACU has been turned into an overflow ICU with the ventilator machines working in there. And so things are a little bit different for everybody right now. I'm actually helping out in the ICU a couple of days a week, which has been something completely and totally different for me. As much as I talk about medicine here, I don't really practice much medicine. As most of you know, I work 100% in the operating room. I do surgery 5 days a week, and that's really my role. I'm putting in sutures. That's what I do. I don't do a whole lot of medicine. So this is a big jump for me just to be around and in the ICU. It's a much different setting than what I'm used to. So that's been something new for me, which I'm sure there are all kinds of things that are new for you, and what you're doing with distance learning, with trying to get through your materials, with being sent home from rotations. And I know how difficult that can be. I've been in contact with a lot of people, and we're working through it, right? We're making things better. Things are getting better. I think it looks like things are starting to open. It looks like people are starting to be able to take their PANCE at least a little bit. And those are great things. So like I've been saying all along, our goal here is to keep moving on, to keep moving forward, to keep growing, to keep learning. I've been using a lot of this time. And again, for me, there's been no baseball, right? Mostly what I do is coach my kids' baseball teams, and that takes up the majority of my time. So one of the things I have right now is a little bit, not a lot, but a little bit more time than I normally would have. And I've been trying to get a lot more reading done. I've been trying to get a lot more work done for Physician Assistant Exam Review, building out some new things, actually some really, really exciting new ideas that I'm going to start working towards this year. If you're on the email list, you heard a little bit about that, I think, yesterday and today, some of the ideas I have coming, and some of the ways I'm going to ask you for help as we move forward, because I'm going to want some input from the community, from you guys, as I move forward on some of the stuff, to make sure it reflects what you're working toward. But I know that it will, so I'm really, really excited about that stuff. Anyway, let's move on and talk about the eyeball. I'm sorry, we're done with the eyeball. Talk about the ear and finish up with the ear. So let's get on to our priming questions. Ooh, I missed the cue on that one. Let's try that again. There we go. Okay, that's better. What is the most common intracranial tumor? What is the most common intracranial tumor? How long does an episode of vertigo usually last in Meniere disease? How long does an episode of vertigo usually last in Meniere disease? Define conductive hearing loss. Define conductive hearing loss. All right, so stay tuned for those. Hopefully you'll pick them up as we go through. Remember, we are working on active studying, so we are participating in this podcast. We are not just listening passively on the radio. We are listening and trying to pay attention, trying to withhold and understand and retain some of this information. So I've gotten great feedback on the priming questions, but you need to participate with them. You need to listen to them. You need to try to think them through in the beginning. It works much better if you don't just ignore them, but if you actually try to process the information and then look for cues as we move through the show. All right, so our first one for today is going to be acoustic neuroma. So this is a slow-growing benign tumor of the vestibulocochlear nerve, which is cranial nerve number 8. It's a slow-growing benign tumor. Those are really, really key terms here. It occurs in males and females equally, and it's usually discovered between the ages of 50 and 60. And these are the most common intracranial tumor, or acoustic neuromas. Clinical presentation here is a sudden onset of unilateral hearing loss that is then slowly progressive. So what that means is that you wind up with the patient has sudden loss of hearing in one ear, but it's not complete. It's a partial loss of hearing. And then it gets slowly worse and worse. They can also have episodes of vertigo, tinnitus, and headaches. In the lab, you can demonstrate, in the clinic when they come in, you can demonstrate unilateral sensorineural hearing deficits. And the diagnosis here is confirmed with an MRI. Treatment is going to be observation with an annual MRI. Remember, these are slow growing, so you have a little time here. You don't have to go right after them. They may require surgical excision and radiotherapy to get rid of. Barotrauma is our next one. This is trauma to the eardrum, secondary to pressure differences between the inside and the outside of the eardrum. Sudden changes in pressure can cause this, like airplane flights or scuba diving. Clinical presentation is a unilateral or bilateral pain, feeling of pressure in the ears, and dizziness. This is a clinical diagnosis, and it may look a little like otitis media. Treatment is going to be prevention. So a couple things you can do with the airplane idea is chew gum, yawning, swallowing, so sucking on some hard candy. Those will open up those eustachian tubes. If you forcefully exhale while the mouth is closed and holding the nostrils, autoinflation, you can sort of open up those tubes. And then a decongestion is recommended if you're congested. I guess that makes sense. Next, we move on to dysfunction of the eustachian tubes. So narrowed tubes is first. Clinical presentation is a fullness in the ears. They come in complaining of decreased hearing, a popping or crackling with yawning or swallowing. Retraction. So you can see, if you look in the ear, a retraction of the tympanic membrane. And a decreased tympanic membrane motility with a pneumatic otoscope. Treatments, again, decongestions here to open everything up. Pseudoephedrine orally. There are some sprays you can use and intranasal steroids. And then you can do surgery in order to open up these tubes if things get really bad. Then you can have overly patent eustachian tubes. So one of the complaints here is an exaggerated ability to hear yourself breathe and speak. And these people actually feel better with a slight upper respiratory tract infection. This is a clinical diagnosis, and you may need surgery to treat this to narrow those tubes. Labyrinthitis is next. This is an inflammation in the inner ear, usually following an upper respiratory tract infection, some allergies. You can be predisposed to this with fatigue, alcohol consumption, smoking, stress, or certain drugs will cause it also. Clinical presentation is acute onset of vertigo, involuntary eye movements, unilateral hearing loss, nausea, vomiting, and tinnitus. This is going to be diagnosed through a history and physical. You can use a diazepam for acute vertigo, and steroids and antihistamines to help calm everything down. Vertigo is our next topic, which is an inappropriate sensation of movement. So it feels like the ground is rolling underneath you. When you're not moving, nothing's happening. So causes tend to be benign paroxysmal positional vertigo is one, Meniere's disease, labyrinthitis, and then some drugs can cause this as well. People usually come in with a sensation of spinning or with the floor moving. They can have nausea and vomiting with this as well. Lab studies and physical exam findings. This is usually a clinical diagnosis. An MRI may be helpful for further workup, but they'll also need a complete audiologic evaluation. Treatment, you're going to want to control the triggers here. So diet, stress, fatigue, bright lights, those sort of things. Again, diazepam for acute vertigo, antihistamines, and compensine for nausea. But we're going to go just a little bit deeper into a couple of those causes here. So benign paroxysmal positional vertigo, BPPV, benign paroxysmal positional vertigo. This is vertigo that typically lasts about 60 seconds. There's a sensation of spinning or moving. And it's believed to be caused by the displacement of small calcium carbonate crystals in the inner ear. So you get these little crystals in the inner ear that help you with equilibrium, and it's believed that those have become displaced. And they cause this episodic vertigo that, again, typically lasts about 60 seconds. There are certain movements that can make this worse, and that's one of the reasons why they think it has to do with these crystals. So it's called a Dix-Hallpike maneuver, which is how you move the head around in certain ways in certain space and can actually cause this to happen. And then the treatment is actually some positioning of the head in specific maneuvers to reposition those crystals. We're not going to get into a lot of depth here because it's not something you're going to normally be doing in your office, and not something I see how they're going to describe on an exam. So for us, it's important to know that benign paroxysmal positional vertigo lasts less than 60 seconds. It usually occurs in middle-aged people, and treatment is through trying to reposition those crystals. Meniere's disease is next, which is, again, this is another one that's a little bit not exactly understood. So this may be caused by inflammation and excess fluid production in the inner ear, but they're not really, really clear on this. But there's definitely excess fluid in the inner ear. The main key here for us is, for right now, is how do we know the difference on a test between benign paroxysmal positional vertigo and Meniere's disease? Meniere's disease has episodic vertigo, but it lasts about 1 to 6 hours. 1 to 6 hours. If you remember, benign positional vertigo lasts about 60 seconds. So it's bad, but it doesn't last that long. These patients can also have low frequency hearing loss, tinnitus, and unilateral ear pressure. Usually this is diagnosed through history and physical, and you can use an MRI to rule out other diagnoses. Treatment is going to be benzodiazepines for acute vertigo, antihistamines. You can do a low-salt diet, and diuretics. They do also do intratympanic steroid injections. And in extreme cases, labyrinthectomies or ablations. All right, so moving right along, we have tinnitus. Tinnitus is a high-pitched ringing in the ears. This can be super annoying, and it drives patients completely insane. They can also get a clicking in their ears, and you might consider getting an MRI again just to look for other causes. Treatment here is going to be prevention, so avoid excessive noise and medications that can cause ototoxicity. Some things you can do once patients have a constant tinnitus is you can mask it with other sounds. So you can run, they can use music, and that'll sort of overlay that tinnitus so they won't hear it in the same way. So if you notice, as I'm going through this stuff, they're kind of quick, right? They're kind of just these short little snippets. There's not a lot to hang on to. There's not a lot of depth in these ideas. So we talked so far about barotrauma. So you come up too fast from scuba diving and your eardrums might pop because the pressure outside is different from the pressure inside. right? So it's more of a description, understanding how things work. We talked about labyrinthitis, which is an inflammation of the inner ear, which can cause some dizziness and vertigo. But we don't have a lot of, we don't have a lot of treatments for this stuff. There's not like a long laundry list of medications and surgeries. And so it's really just separating these ideas out in your head, keeping track of each one, making sure you know the one or two little keys to it. Like I tried to cover for Meniere's disease, it's a longer vertigo. For benign positional vertigo, it's a shorter vertigo. For tinnitus, it's just a high-pitched ringing in your ears that's usually caused by excessive noise over long periods of time. There's not a lot of things to ask questions about. There's not a lot to really go on here. So that's kind of why I'm zipping along. And you need to review them, but you're not going to get a ton of questions on them, right? It's not that easy to write questions on a lot of this stuff. And that's what I try to focus on is what are you going to get questions on? What's going to be easier or harder to write a question on to lead you down the right path for? All right, so let's move. Let's keep moving. Mastoiditis causes is secondary to otitis media. This is an infection of the mastoid that comes following otitis media, right? So we get a redness and swelling behind the ear. And that's going to be your hallmark sign here. As a kid who's got otitis media, but then you look behind his ear and the area over the mastoid is just red and swollen and yucky looking. Patients come in with a high fever, ear pain, drainage from the ear, and can have hearing loss. And this is typically a clinical diagnosis, but a CT may give you some more information that you want. Treatment is going to be prevention. So treat the ear infection with antibiotics. IV antibiotics may be necessary, like cephalosporins, and then surgery or laryngotomy to drain the middle ear. In extreme cases, removal of the mastoid may be necessary. All right, we're almost done for this session. The only other thing I wanted to talk about before we wrap up for today is hearing impairment. And this tends to be a little bit difficult for people to grasp and super easy to write test questions on, so you're going to see these. So there's a couple different types of hearing impairment: conductive versus sensory versus neural. They usually lump sensory and neural together, so that's helpful. And conductive is out on its own. So conductive is a problem conducting the sound waves through the structures of the ear. So sound waves don't get in. So for me, I think about things like, we talked about cerumen impaction last episode. So like wax in your ears keeps the sound from getting in. Really, really straightforward. Sensory is a problem with the inner ear and usually is related to the loss of the hair cells that help to transmit that stuff. The neural hearing loss, the problem is the damage to the vestibular cochlear nerve, which is cranial nerve 8. And this is the least common form of hearing loss. So conductive is something blocking the ear. Sensory is usually related to the loss of the hair cells within the ear, and that's usually secondary to aging. So you can also get sensory and hearing loss from significant noise exposure, from head trauma. But again, a lot of times it's due to age-related loss of the hair cells within the ear. And a neural loss would be like the acoustic neuroma we talked about earlier, and multiple sclerosis would be another one. So for hearing loss, how do people present? Well, they present with hearing deficit. Labs and studies. So this is where we complicate things even more with the Weber and the Rene test. With the Weber test, you take a tuning fork and place it against the forehead, equidistant from both ears. A patient without hearing loss will hear the tuning fork equally in both ears. So we can all picture that. You just take a tuning fork, you hit it, and you put it on top of the patient's head or on their forehead, equidistant from both ears. And if everything's normal, you hear everything the same in both ears. The Rene test is that you place the tuning fork on the mastoid process, and then once the patient can't hear the sound anymore, you take it away and hold it next to the ear. And in normal hearing, it'll be louder with air conduction than bone conduction. So what that means is you'll put it against the mastoid while it's ringing. You leave it there until they just can't hear it anymore. And then you move it next to the ear, and all of a sudden they can hear it again because the air conduction is louder than the bone conduction. This you may want to go over to the website and review because listening to it may be a little bit tough to picture in your mind. But I think if you don't close your eyes if you're driving or running or something like that. But if you close your eyes and picture that just for a minute, the Weber test puts the tuning fork on the forehead. The Rene test puts it behind on the mastoid. For conductive hearing, If you have a conductive hearing loss, the Weber test, the patient will report the sound louder in the affected ear because it'll conduct through the bone. So even though but what happens is conduction through the bone gives the impression of being louder. So since they don't have air conduction, if you have conductive loss, if it goes through the bone, it'll sound louder. So that they will have an increase. They'll think it's louder in the affected ear. If they have conductive hearing loss, again, that's a blockage, let's say, like wax in the ears. For the Rinna test, the sound will be louder on the mastoid with bone conduction than near the ear, right? That makes sense because they don't have air conduction. But if you put it on the bone, it'll be louder there. Or in a normal ear, remember, it's louder next to the ear, not on the bone. If they have sensory neural hearing loss, the Weber test is louder in the unaffected ear. And the Rinna test, the sound will be louder off the mastoid with air conduction. And then obviously you can refer them for a formal hearing test by an audiologist. But you need to review that section. I think that's just it's not super complicated if you understand. Once you get the picture of it, it's hard at first, but once you grasp it, it makes a lot of sense. And then it's easy to get that test question right. And you're probably going to see one of those. Treatment is prevention. Avoid excessive noise, quit smoking, don't put things in your ears like Q-tips. Conductive hearing loss is the most treatable form of hearing loss because you can just take the wax out or whatever's blocking the issue. And then hearing aids and cochlear implants for sensory neural hearing loss. Perfect. So that will actually wrap up the ear for us. That was the middle ear and hearing loss. The inner ear and hearing loss. In the next episode, we're going to start moving into, I think the nose is all next week. And we'll start covering that. But for right now, I want to just move into our testing tip for today. And this is one that I think is extremely important and one that I don't think we spend enough time on. I don't think anyone spends enough time on. And I don't even know that you know about this one, but this one is huge. Today's study tip is going to be to build up your confidence by remembering past successes. And this is extremely important and extremely easy to do. Where you gain confidence from are past successes, things you've done well in the past. If you've done well on exams, then you have a lot of confidence when you go into an exam. If you've done poorly on an exam, then you lose some confidence on your way into an exam, right? I think we all understand that. That's all pretty normal. What I want to point out is you can use on purpose your past successes to improve upon your current level of confidence. So even if you haven't done well on exams recently, at some point you've done well on exams. At some point in the past you've passed tests, because I know that because you're here. You wouldn't have gotten this far along if that weren't the case. So with that being said, if you take a few minutes and remember those successes, remember the times when you did well, remember the times when you did really well, it will help boost your confidence and make you feel a whole lot stronger on the way in. Interestingly enough, it doesn't even have to be on a similar thing. It doesn't have to be on passing tests. It could be confidence in athletics, in running. It could be confidence in keeping promises to yourself, like we talked about making your bed. If you build up that making your bed every day and you've kept that promise to yourself, that's a place you can look back to for confidence. It's a success in your life. If you've accomplished anything from tying your shoes to getting into PA school is a great one. You can use any of that. You can use to help build your confidence on the way into your exam. You know that you've done things successfully in the past, so you can know that you have an image, you have an actual reality that says, I've been successful in the past, I can be successful in the future. Even if you've done bad on certain things, you can use those past successes to move forward, to build things up. And to me, that's a huge idea. That's extremely important. I hope that you don't gloss over that one and take some time to really reflect on it, because that one is extremely important, especially as you move towards your PANCE. All right, let's wrap up with our priming question answers for today. What is the most common intracranial tumor? What is the most common intracranial tumor? And the answer was an acoustic neuroma. That was all the way back in the beginning. How long does an episode of vertigo usually last in Meniere disease? How long does an episode of vertigo usually last in Meniere's disease? It's about 1 to 6 hours. Define conductive hearing loss. And this is a problem where the conduction of sound waves into the ear through the air. Conductive hearing loss. All right. Sweet. So that brings us out to the end. That will finish up the ear. Not a whole lot, like I said, not a whole lot to cover here. Things are pretty straightforward, not really a killer. I think you should be able to handle most of the stuff in the ear. The Weber and Rena test are a little bit difficult, but I think if you go over them once or twice, draw yourself a little picture, watch a couple YouTube videos, I think it really becomes very clear and very easy to get those right. I don't think it's worth skipping those. I will point out to skip things when I don't think you should bother with them. That's not one of them. That one I think you can handle. I really do. So that'll wrap us up for today. Next week, we'll move into the ever exciting into the nose, and we'll cover that up. Hopefully, things will be open up a little bit more in general. You'll be taking your exams, maybe even back to some rotations. We'll see how things go in 2 weeks. But I'm hoping and praying that that's the case. So anyway, I'd like that to take us out for today. If you haven't been over the website in a while, go check it out. Definitely scroll down to the bottom, click on Blueprints. You can find all the past episodes, everything you've been looking for. And definitely go over there and sign up for the email list. And that's how we'll let you know about the plan I have for working with the people over at the Rutgers PANCE review online system. And that'll come out next week. So anyway, I just want to wrap that up for today. Take care. Thank you so much. And I will talk to you next time.